Okay, thank you for being patient with me. So, my talk is twofold, sacroiliac fusion in pregnancy if there are orthopedic considerations, and I'll make some comments about the postoperative circumstance. How to identify a patient with postoperative sacroiliac pain? This is an objective. Is it different? And sacroiliac fusion in women of childbearing years, orthopedic considerations, which may affect delivery. So the location of the pain, the physical examination, I think it should be the same. The underlying pathology, however, requires consideration of three theories. The ligament, is it the ligaments that are painful from laxity? Well, we've heard a lot already about how important the ligament is and how much the laxity may present a role, and that is a consideration. There is the muscular basis. Is this deconditioning? Is this strain, spasm, and so on, something that should refer and be subject to modalities? Or is it articular surface basis? That is it that the joint itself, the sacroiliac joint? And I think there's two elements to that. The early element, which is that the SIJ is altered because the ligaments are lax, or is it late because of some damage to the sacroiliac joint because of the ligament laxity? So next question is, why does the sacroiliac joint become painful? And I want to emphasize that my perspective on this is different from what has been presented, because I'm talking about the very late surgical stages of the sacroiliac joint to explain my model, which is that the late chronic sacroiliac pain is actually osteoarthritis. And so I would make these points. If you do study the sacroiliac joint, you must do so in the plane of the joint. So a typical CT scan would be the axial, the sagittal, left and right, the coronal. But if you do paraaxial and paracoronal and parasagittal films, you see other things. So for example, here's a plain sagittal cut of the sacroiliac joint. This is an oblique sagittal cut where you can see the sacroiliac joint much better. This is a plain coronal cut of the sacroiliac joints, but if you do a paracoronal, you see the sacroiliac joints in the recess quite differently. If you see a true coronal of the sacrum, you see even more, including the vestigial segmentation and so on. And I believe that that kind of thing is important at the time that you're deciding about the underlying pathology of the sacroiliac joint, because if you study the sacroiliac joint in the plane of the joint, you see things like this, which is the degeneration or disease of the sacroiliac joint and subluxation, which is an orthopedic consideration. It means that the joints are subject to orthopedic disease rather than, let's call it, muscular ligamentous disease or laxity. And then you see other things like this, which is subluxation. It's actually like a spondylolisthesis. And one might then consider, where's the pain coming from? Is it coming from the strain of the ligaments in the effect of the listhesis? Is it coming from the incongruence, the loss of congruence because of the laxity? Or is it coming from the sclerosis and reactive changes that are typical of osteoarthritis? So when you get several sacroiliac CTs, and you look at, in this case, the parasagittal films, this is what normal looks like. And this is slight osteoarthritis, more osteoarthritis, and severe osteoarthritis. So to an orthopedic surgeon like myself, this imposes a sense of responsibility. If it's osteoarthritis, there are principles in the treatment of osteoarthritis, which include, if you're going to treat this surgically because of some unsalvageable deformity or disease, you must create a biologic milieu, you must restore the deformity, you have to resolve the interosseous pressures, and so on, all of which are common with other types of arthroplasty. Here is another example. This is an extreme example of osteoarthritis of sacroiliac joint, and you can see how it is differentiated by the different views, which I consider important. So if I've done that, and I have what the 10 views, for example, 1 through 10, and then I look at each of the views individually, you'll see that you can make discriminating judgments about normal, some intermediate phase of degeneration, and a severe phase of degeneration. And we need to know that because it does pose responsibilities to the orthopedic surgeon, which follow the principles in the rest of orthopedics. So, my opinion, why does this SIJ become painful in the late state? It's osteoarthritis. That's my impression. So the next question, SI fusion in women of childbearing years, orthopedic considerations which may affect delivery. So mechanics. So my preferred model for the sacroiliac joint and its motion is the Lavigno model. And what Lavigno said was when the right leg, in this case, is forward, the hemipelvis rotates backwards. And if the left leg here is an extension, the hemipelvis rotates forward. And it's a relatively easy model to understand. And it comes into play if one immobilizes the sacroiliac joint on one side. So if you are able to successfully immobilize the sacroiliac joint on one side, you block these motions quite effectively. Waiting for the slide to change. And you can see that on both the axial and the sagittal views. However, there's more to it because in the delivery circumstance, it's not the situation of the reciprocal motion of gait where the right hemipelvis is going backwards and the left hemipelvis is coming forwards, because in delivery, both hemipelvis are coming forward. And that's what allows the birth canal to open for the child to be delivered. So this is studied by SPG, and what is the range and what we can learn from the available studies and the range of motion of the SI joint. Well, many people have studied this. So translatory motion in millimeters may be, wait for the, a little slow, whoops. The computer's moving a little slowly. So it may be as much as 16 millimeters by some measurements, or as little as half a millimeter. And rotatory motion has some same level of variation between 3 and 19 millimeters in some circumstances, and between 2, I'm sorry, my computer's moving very slowly, 2 and 1 in others. So I'm afraid we don't get the guidance that we need from simple understanding of motion. So is there another way to look at this? Yes, there is. So I would refer you to the Scholten model. And what Scholten said was that in order for one sacroiliac joint to move freely with respect to another sacroiliac joint, both sacroiliac joints need to be universal joints, and they need to be moving in 3 planes. And in order for these two to be working in 3 planes, the symphysis is also a universal joint. So in the circumstance where Scholten's model is fused, that has implications, of course, for the sacroiliac joint of interest, but it has implications for the contralateral sacroiliac joint and the symphysis as well, because what you have done is you've created a situation of 2 points of contact here and here, contralateral and the symphysis, which now you've effectively made a hinge. And geometrically, this sacroiliac joint can no longer function as a universal joint. Neither can the the symphysis pubis. And you have this point, a situation where you have 2 points of contact. In other words, this hemipelvis has become a hinge, whereas this one has become fused, and it has obvious implications for the birth canal and the delivery of the child. So can we learn something from anthropology? Well, yes, we can. In the inlet of the birth canal, this hypothetical series of measurements does not actually involve the sacroiliac joint, but in the mid circumstance where the infant is engaged, the ischial spines come into play, and then the outlet circumference is something else. So there is this point in the delivery of the child at the midplane where the child's head is engaged, where the mobility of the ischium, the ischial spine is very important. So that's so in non-human primates, the birth canal is very small. In Homo sapiens, it's very large. But even if it's large, there are some circumstances where it's not large enough. So we have this concept in OB called dimorphism, which is the disproportion between the size of the head and the size of the body. And the size of the head is larger in males, which creates questions of engagement and passage of the child through the birth canal. So the body has adapted the side or the pelvis for the female to be longer in this dimension, which makes the pelvis and birth canal larger. So what are the delivery considerations? Well, there's relative simple considerations of these dimensions, but notice the relevance of the ischial spine here. There we go. So the body, that is the infant's body, adapts to the changes in the canal dimensions by these so-called cardinal movements, where the child's body and head is rotating its way through the birth canal. What's important about that is the birth canal will then determine things like, the presentation of the child's head, whether it's vertex or sinciput or brow presentation. But it also determines other things as well, such as the remodeling of the child's head. So if the baby's head is seen in this plane, and here's the distance of the between the ischial spines, which is considered engagement, the baby's head reaches to this point, and then if the ischial spine, let's say, is not as mobile as it should be, the child's head may remodel, or there may be other types of birth difficulties. So cesarean considerations. The indications for cesarean delivery are different, from pre-labor to intrapartum, meaning during the delivery process, and the failure of the child to progress because of cephalopelvic disproportion, the dimorphism that I was telling about. Intrapartum, that's half of these, which is significant. Fetal malpresentation is another, and fetal macrosomia is another, and all of these are dependent on the dimensions and shape of the birth canal, which is in turn dependent somewhat on the mobility of the ischial spines. So engagement is the term. Does the baby, as the baby is descending through, is the baby's head engaging and able to get past the ischial spine, which is right here. And this, if this kind of difficulty is associated with adverse outcomes, meaning there's a 4.8 times incidence of wound infection. There is a 2.9% incidence of postpartum hemorrhage. There is a 7% incidence of urinary tract infection, a 2 times need for blood transfusion, 3 times incidence of fever, and a 4 times, let's call it 3.6 times need for maternal intensive care unit admission, all because of the decision to do an emergency cesarean section. There are also adverse outcomes for the baby too, including birth asphyxia and meconium staining and admission to the neonatal intensive care unit. So how is the decision-making process established? This is a study of 180,000 nulliparous women, that is, women who have never had a baby before, in the 8 major centers of Hong Kong. And you can see how the decisions are made for cesarean section between virtually all being made in the pre-labor circumstance, which is with more senior obstetricians. And then there is another group which is presenting for cesarean late because of assisted vaginal birth. That's what this is. Forceps are unsuccessful at delivering the child. So this becomes an emergency cesarean section for failure to deliver. So what is my personal experience? I will tell you it's very brief. I reviewed my 635 patients in my private practice. There was another practice at the hospital between 1995 and 2024. These were patients, female patients less than 40 years of age, basically women in childbearing years. I was only able to reach 9 of these, of which 5 had babies after sacroiliac fusion. 3 had vaginal birth with no complications. 1 described her delivery as difficult, but otherwise her result was, quote, wonderful, she would say. And then we have, waiting for the slide here, sorry about that. We had these following cesareans, and none of them was done because because the woman had a sacroiliac fusion. 2 were done just as a precaution for personal choice. 3 were done because the first 2 were twins, and the last one was a singleton, and they wanted to follow the twins with a cesarean. And the 3rd was for cardiac reasons. This is supraventricular tachycardia. So basically, the decision for a cesarean was all based on personal choice. So after that, what else can we learn? So there are some studies about trauma and the birth canal, pelvic ring fracture, and the management of subsequent pregnancies. What this says is that pelvic ring fracture and asymmetry does not determine whether they get a cesarean section. Although there is a perceptible increase in women getting C-sections after pelvic fracture, and there's an increase in cesarean sections generally, up to 1/3 of deliveries now. Right. There is no clear evidence to support that an elective cesarean section is necessary as a sole indication after prior pelvic fracture. The consideration would be if the birth canal is an indication, and that is decided by a single X-ray, but generally there is no guidance and no recommendation about vaginal deliveries after pelvic fixation, and that includes the persistent residual internal fixation devices. From this, the reasonable conclusion would be that the mother, of course, should be counseled too. But there is no suggestion that avoiding vaginal delivery can be supported. And the recommendation, it's not a straightforward recommendation. So this is a second study that talks about the residual retained internal fixation devices, and they found that the mode of delivery was not affected by the retained internal fixation devices, including iliosacral implants, but a pelvic asymmetry because of fracture, post-fracture deformity is an indication for cesarean, but that's determined by a simple radiograph of the pelvis. So, conclusions. The peripartum circumstance, the delivery circumstance, the mechanism of sacroiliac pain or hemipelvic pain or pelvic girdle pain, I think would respond to conservative care, which would be centered on physiotherapy and avoiding interventions, obviously. Late postpartum pain is a different consideration. And I think, and in my opinion, based on these CT scans, it's based on joint surface damage and injury, which is treated and diagnosed the same as sacroiliac disease of any other cause. So the recommendation, preventing second stage cesareans, as we saw, is a reasonable goal. Planning, counseling, observing, and having a low threshold for performing cesarean. The magnitude of the effect of the change of the movement of the ischial spine is really unknown because of the variations of the woman's pelvis. The variations in pelvic anatomy is so common that a significant fraction of patients will undergo successful vaginal birth without interference of the sacroiliac fusion. There are no recommendations either in trauma or surrounding sacroiliac fusion literature which suggest the incidence of cesarean. But obviously, women should be counseled and discussed with their obstetrician about lowering the threshold for a consideration of a cesarean, especially in the circumstance of stalled labor or cephalopelvic disproportion. Thank you.